Medtronic technologies impacted more than 72 million people in the last year, equating to 2 people every second. Harnessing the power of technology to take healthcare further, each technology has unique benefits designed to serve patients. The goal of this program is to get closer to the patient and delve into the challenges and impact of each technology in practice. This is the Medtronic MedEd Learning Experience. No monitoring system should be used as the sole basis for diagnosis or therapy, and they are intended as an adjunct in patient assessment. Reliance on a single monitoring system alone for patient management is not recommended. The contents and conclusions of the following programs are solely those of the speakers unless otherwise cited. The speakers are responsible for all content and any necessary permissions. The speakers receive funding from Covidian LP, a Medtronic company, for this speaking engagement. Medtronic's medical education programs are offered to provide attendees education on FDA-cleared indications and use of our products when applicable. For this segment of the series, a discussion on patient safety and procedural sedation. How are we assessing patients for anesthesia? To help answer this question are gastroenterologist Dr. Ashish Chawla and CRNA Brian Berry.
So Brian, how exactly are we assessing patients for anesthesia? I know we use ASA guidelines worldwide to identify patients' overall health or prior exposure to anesthesia to help stratify them, but how exactly does this ASA system work?
Good question, Dr. Chawla. The ASA, or the American Society of Anesthesiologists, physical status classification system, is really a numeric value from 1 to 6 on determining the patient's pre-anesthesia comorbidities. So when you start on the left side, the ASA 1 is a normal, healthy patient. You move to an ASA 2, it's a patient with what we classify as a mild systemic disease. Moving over one, ASA 3 is a patient with severe systemic disease. And then ASA 4 is a patient with severe systemic disease that is a constant threat to life. And an ASA 5 is a patient that isn't expected to survive without an intervention, an operation. And then ultimately, the ASA 6 is a brain dead patient.
So when we think about anesthesia, are patients and their adverse events similar in the operating room patients versus when we think about non-operating room anesthesia?
Yeah, Dr. Chawla, procedures have actually shifted in a great respect from the operating room to the non-operating room environment. And we refer to the non-operating room environment. Examples would be the GI lab, the interventional radiology suite, the cath lab. And what we've seen from 2010 to 2014 is a shift from 28% to almost 36% of these cases occurring outside of the operating room. In addition, there's a big push for these NORA, non-operating room procedures, to be the sedation to be provided by non-anesthesia providers, non-anesthesiologists or non-anesthesia providers. So you have the IR suite RN providing the sedation. There's the cath lab RN providing the sedation, or the GI RN providing the sedation. Not in all circumstances, but we are seeing a big shift from the operating room to the non-operating room when it comes to procedural sedation.
So when you see that, do you find that the patients who are in the non-operating room environment higher risk, or are they the same risk as patients who are in the operating room environment?
Well, the statistics and the data is going to tell you that non-operating room sedation is at more risk than in the operating room. And there's several reasons for that. Patients, when you look at studies and statistics, patients are older receiving non-operating room sedation. Patients are sicker the ASA classification system that we just reviewed, statistically speaking, higher ASA classes, 3s and 4s, are undergoing sedation in the non-operating room environment and compared to the operating room environment. So those two factors alone make the non-operating room environment a more risky or sedation case. In addition, so when you're looking at risk stratification, they're twice as likely to have an adverse event in that non-operating room environment due to the advanced age, due to being more sick, and being not in an operating room has its own problems and consequences. So all those factors make a non-operating room sedation case more likely to have a respiratory event.
Wow. So these are pretty striking statistics. We're actually pushing patients outside of the operating room into the non-operating room environment, and the adverse events there are higher. Given these findings, what has our recent national committees on patient safety suggested? What should we do different?
Well, according to the 2022 Stolting Consensus Conference on Crucial Patient Safety Issues in Office-Based and Non-Operating Room Anesthesia, they recommended a thorough preoperative assessment of that ASA classification, in addition to, and I emphasize to those participating in our talk today, that all people should adhere to the ASA standard for basic anesthesia monitoring, which includes the big five, right? The non-invasive pulse oximetry, the non-invasive blood pressure cuff, heart rate, respiratory rate, and end-tidal CO2 monitoring.
Brian, I'm going to ask you another question. Why do you think these adverse events are occurring actually in non-operative room environments? Is it just a patient selection? Are we not risk stratifying them well enough? Is there a misclassification going on?
I think it really could be both patient population and the classification itself. The patient population, we kind of hit this previously, they're older, they're sicker in a non-operating room environment, and the non-operating room environment itself carries risk. So I think those factors are patient related. And then the misclassification that you brought up, there is a really great article in Anesthesiology News of the May 2023 publication. And what it says is a lot of the time we're misclassifying patients in relationship to their ASA classification. So we could probably do a better job at that preoperative period in assessing our patients and the risk factors for undergoing sedation in a non-operating room.
I agree. Thank you so much for your time.
Thank you, Dr. Chawla.
Please tune in next week for a new segment from this series wherever you find your podcast. This is the Medtronic MedEd Learning Experience. Thank you for listening.